Dan, let's talk about initial lines of therapy, and we're going to talk specifically about sort of goals of frontline therapy. You've got all sorts of kinds of patients. Some may be resectable, some clearly aren't, some symptomatic, some not. Give me sort of your broad overview when that new patient comes in to see you, how you make that assessment and what those goals are going to be for that patient walking in the door.
Well, sort of a bone I have to pick is with mutational testing. We're talking about individual personal therapy, but I've been doing that for 40 years, is I make individual decisions in every patient. And if you say statistically the most common frontline regimen in the US is FOLFOX/bevacizumab, that can't be the right treatment for everybody. If someone has 5 small pulmonary nodules and is asymptomatic 4 years out from their primary colon, that patient is very different from someone with peritoneal metastases, symptoms, weight loss, pain, and a BRAF mutation.
Right.
One could live for 5 years, and the other one probably will live 1 year.
Yeah, that one you could just rub a little Xeloda on them and they'd be fine, right?
Yeah, and for that patient, they've had metastatic disease for 4 years.
Right.
You just know it.
Yeah.
Now you know it. So I think in the first patient, single-agent capecitabine might be the right answer. Or that, in the other patient, probably FOLFOXIRI or FOLFIRINOX, whichever term you want to use, probably is important because they may never get to second-line therapy. And you're never going to shrink a tumor with single-agent therapy. So that's not going to happen to any great degree. So that's how I balance the pace of the disease. How did it occur? Synchronous, bitachronous? What is their mutational status for, not so much for RAS, but BRAF in terms of prognosis? And then the tools and what are our expectations? For the potentially resectable patient, I think you need most therapy up front. It turns out cetuximab didn't really, in the trial with cetuximab, make a difference. Although in the 80405 trial, more people got resections, I think 2 to 1, in the cetuximab arm. So, we'll talk more about neoadjuvant therapy and when you should use it, but I think as Cathy was saying, you have to make a decision about resectable, non-resectable up front, not after 7 lines of therapy.
Yeah. I've been struggling with this induction concept. I was actually, just like Dan laid out, give the least amount of chemotherapy kind of guy to control a patient and then save things for downstream. But more and more in randomized clinical trials, we're seeing, combination FOLFOXIRI, whatever, combinations, kitchen sink combinations that are resulting in OS, PFS, resection rate improvements in an unenriched, if you will, anybody walks in the door metastatic cancer population. Is your mindset changing away from the capecitabine single agent, if they're really quiet, to giving them at least some induction therapy?
Once again, it depends upon the patient. I evaluate the patient and then I make that decision. I mean, if you've got someone with borderline resectable disease, you kind of want to provide them significant therapy up front to give them that chance of having a curative resection. And then you'll have the really young patient with high degree of tumor burden that you may want to be very aggressive on. So I think it really just depends upon your patient population.
But didn't we just see, so Dr. Bendel's study with combination chemotherapy, improving, we have the old FOLFIRINOX study, or FOLFOXIRI, I never remember which it is, that actually shows an OS and PFS, not just the more aggressive bad tumors, but in all comers. And so that's what I'm getting at, so are we still individualizing as we've been doing based on the clinical scenario, or is anybody up here ready to say that almost every patient with frontline colon needs 2 months of induction chemotherapy? Tony?
No, I don't think so. I think the studies that with the 3 drugs with a more aggressive regimen do suggest that there is a subgroup of patients who would benefit. And the clear one that is clearer now became a little bit more gray a few years ago is the liver resection. The liver resection, I think, consistently now, and I'm changing my mind about that, consistently showing that you probably benefit from a 3-drug approach for 2 to 4 months. Increase the rate of R0 resection and perhaps even resection. The BRAF mutated group, which does the worst, seems to benefit at least now in 2 studies, albeit one is small, the other one is a piece of a study, but it does suggest that that subgroup of patients seem to benefit from the 3-drug approach. The others, frankly, if you look overall at the survival of the 3 drugs plus biologic, and look at CLGB 80405 or FIRE3, and you look at the survival, they're in the same range. So a sequential approach would still make more sense. In the BRAF mutated, you may not have the luxury of that sequential approach because patients barely make it to second line.
So what's the control arm on a cooperative group frontline study?
It remains sort of FOLFOX bevacizumab because that is primarily what people use. And in 80405, I think 70%
Yeah,
of
70%.
individuals chose that when they were asked. It is what we use. In Europe, it may be the same. FOLFIRI is more commonly used.
Yeah, I have to admit, I'm kind of turning to the FOLFIRI train. FOLFOX has so many long-term side effects, and FOLFIRI patients tolerate much better. You actually have some better responses with irinotecan.
And hair loss is incredibly cool.
It is.
It really
it
is. It's the thing to do.
So
I actually like FOLFIRI bev.
Yeah, if they're okay with the hair loss, then I go with that one.